Hello, my name is Jacob Avila, and for this week's EM5, we're going to talk about serotonin syndrome. Now, why is this important? This is important because we often miss it. We miss it because we don't know how to recognize it. In 1999, there was a survey that was done that concluded that 85% of clinicians had no idea what serotonin syndrome was. And in 2003, the Libby-Zion law was enacted because of a presumed missed serotonin syndrome. And in the U.S., this is why we have work-hour restrictions for residents. Granted, the identification of this disease is probably a lot better these days, but we're still behind where we should be. Now, why do we miss this disease? The reason we miss it is that, especially in the early phases, they can present with kind of non-specific symptoms like hypertension, tachycardia, tremors, and diarrhea. Also, serotonin syndrome presents very similarly to a lot of other diseases, and we'll go through the differential of these a little bit later. When a patient presents to your emergency department with serotonin syndrome, they can go from civilized to crazy very quickly, and they can actually die. Patients with this disease have a mortality of 2 to 12%, and they'll die from kidney failure, respiratory failure, or DIC. Now, how does this actually happen? Serotonin is found mostly in the periphery and is found on platelets and in the small intestine, but the serotonin that we care about is the serotonin in the brain. It's formed in the raphe nuclei, and as you can see from this graphic, it has its fingers pretty much everywhere in the brain. More specifically, we care about what happens at the synapse. Serotonin is released, binds to the receptor. The stuff that doesn't bind to the receptor is degraded by MAO, or monoamine oxidase, and it can also be degraded at the receptor once it's used. Now, there are a lot of serotonin receptors, about 7 main ones and about 14 subtypes total. Fortunately, there's really only 2 that we care about, 5-HT2A and 5-HT1A. 5-HT1A is thought to be responsible for myoclonus, hyperreflexia, and mental status changes. Now, this stuff definitely makes your patient crazy, but the stuff that kills your patient is 5-HT2A. That is responsible for the hypertension, tachycardia, fever, and neuromuscular excitation. The hypertension and tachycardia is thought to be due to stimulation of the adrenal gland, and the neuromuscular excitation is thought to be due to a direct effect on the brain. Also, that neuromuscular excitation makes the muscles kind of rigid, puts you in a hypermetabolic state, and can cause a fever. Serotonin also directly stimulates the hypothalamus. That's another thing that can cause a fever. The most important thing in the evaluation of a patient with serotonin syndrome is to know what drugs they're on. Classically, the diagnosis of serotonin syndrome is done with the presence of a serotonergic medication and the presence of altered mental status, increased neuromuscular tone, and autonomic instability. Now, which drugs can cause serotonin syndrome? There's actually a lot of drugs that can cause serotonin syndrome, but the ones that I think are important in the ER are antidepressants, any street drugs, dextromethorphan, which is found in cough syrups, some narcotics, and linezolid. Surprisingly, linezolid was initially invented to be an MAOI antidepressant, and they found that it actually had better antibiotic properties, so they use it for that. Now, as far as narcotics, there are a lot of different narcotics, and most of them cause serotonin syndrome, but there's been 3 that have not been reported to cause serotonin syndrome, and that is codeine, hydrocodone, and morphine. On the flip side, those that cause serotonin syndrome that you really have to worry about is tramadol, fentanyl, meperidine. Fentanyl has a really short half-life, so that's not that scary to me. Tramadol is the most common. A lot of our patients are on tramadol, and meperidine is important because the half-life is so long. So how do you actually diagnose serotonin syndrome? The first thing you need to do is narrow your differential. You can usually do that with a history and a med list. If you have these, it's actually pretty easy. However, many times we don't have this, and we'll have to rely on our physical exam, lab tests, and imaging to figure out if the patient has serotonin syndrome or one of the other things in our differential. Patients with sepsis or CNS infection will present with altered mental status, fever, tachycardia, but they'll usually have hypotension, and they'll have a dirty urine, dirty CSF, maybe a white count in the 30s. Patients with malignant hyperthermia usually present after inhalational anesthetics. They will present with a fever, with hypertension, with tachycardia, but they'll have normal reflexes. Patients with anticholinergic toxicity will present with altered mental status, tachycardia, and hypertension, but they'll have normal reflexes and they won't be sweaty. Serotonin syndrome, they'll be sweaty. With sympathomimetics, it's very similar. The only difference between that and serotonin syndrome is, of course, the medication, and sympathomimetic toxicity will have normal reflexes, and serotonin syndrome will have hyperreflexia. Patients with delirium tremens will present similarly, but they'll have zoopsia, which is where they hallucinate animals, and they'll have normal reflexes. Opioid withdrawal, they'll present similarly, but they'll have very mild elevations in the heart rate and in the blood pressure, and there'll be a lot of yawning. NMS is kind of the big one in the differential because these patients present the most similarly. Patients with NMS have slowly progressive symptoms over days rather than hours. NMS happens with neuroleptics, that's antipsychotics, and these guys will have normal or diminished reflexes compared to the hyperreflexia of serotonin syndrome, and they'll be rigid. Now, there are two decision rules you can use to help you. There's a Sternbach and a Hunter. The Sternbach criteria are considered a little bit older and maybe not as accurate. It especially misses serotonin syndrome in the mild to moderate categories. The Hunter criteria is probably a little bit easier to use and more accurate. It has a higher sensitivity and specificity when compared to the Sternbach criteria. As far as treatment, always start with your ABCs. If you can't fix them with supportive care, you might want to start benzos. Benzos are good for the neuromuscular agitation and the psychosis. If they get into the moderate to severe categories, Cyproheptadine is going to be your drug of choice. Cyproheptadine is an antihistamine and an anti-serotonergic medication. The dosing is a 12 milligram loading dose PO, followed by 4 to 6 milligrams every 6 hours as needed. The problem with Cyproheptadine is that it's a PO medication, so there are some other medications that you can do IM and IV. You have Chlorpromazine and Olanzepine and propofol and Precedex. You can use those as well. So that's it for this week's EM in 5. My name is Jacob Avila. You can find me on Twitter at ultrasoundmd.